In the next few minutes, we are going to continue speaking about hemolytic anemias, especially the alpha thalassemia and the sickle cell disease, their diagnosis and management. Alpha thalassemia, this slide we have seen this before, and we have spoken that alpha globin are carried on chromosome 16, and we have 4 genes responsible for the alpha globin. So what happens? What's the alpha thalassemia? The decreased production of alpha chains can result from deletion of one. If you speak of one of these gene deletion, this is a silent carrier of no clinical significance. But if there are 2 deletions, we get alpha thalassemia trait with only mild hypochromic microcytic anemia. But if you have 3 deletions, it's going to result in what we call the hemoglobin H disease. Hemoglobin H is formed of 4 beta chains, can be present in hemoglobin electrophoresis, variable severity of chronic hemolytic anemia. It's more like beta thalassemia intermediate rather than beta thalassemia major. But if you have deletions of 4 alpha genes, we get what we call the hemoglobin BART. It's composed of 4 gamma chains. It's incompatible with life because it has strong oxygen affinity, does not deliver oxygen to the tissues. Alpha thalassemia is inherited as an autosomal recessive disorder. Let's move to structural hemoglobinopathies. The most common example is sickle cell disease, the most striking example. Sickle cell disease is a mutation of the beta globin gene on chromosome 11. There is a valine is substituted for glutamic acid, and this results in the formation of hemoglobin S. The hemoglobin which is formed is hemoglobin S. It is an autosomal recessive disorder. What's the difference between red cells containing normal hemoglobin and red cells containing hemoglobin S? Red cells containing normal hemoglobin, they are disc-shaped, they are soft, they can move through small vessels easily, through the meshwork of the reticuloendothelial system easily, and they live for 120 days. But if the red cells, they contain hemoglobin S. These cells, when they pass through areas of low oxygen tension, such as the capillaries or the meshwork in the reticuloendothelial system, the presence of hemoglobin S results in polymerization of this hemoglobin S. This results in change in the shape of the red cell. They become sickle-shaped. They are hard like a piece of wood. They are destroyed when they pass into small blood vessels. They get stuck in the small blood vessels, and their lifespan is only for 120 days. This is what I have explained before. And so in sickle cell disease, we have 2 main phenomena. We have a hemolytic anemia because there is decrease in the lifespan of these red cells, and we have a vasoocclusion because these sickle cells, they get stuck to the wall of the blood vessels, they occlude blood vessels, and you get vasoocclusive crisis. So the clinical manifestation sickle cell disease, we have 2 beta globin genes. If both are affected with mutation causing hemoglobin S, we get homozygous sickle cell disease, what we call sickle cell anemia. Sickle cell anemia presents usually in different forms, and its complications are numerous and severe. Vasoocclusive crisis. Vasoocclusive crisis, obstruction of the blood vessels. This can occur anywhere in the lungs, in the liver, in the bone, in the muscles, in the brain, in the spleen, the penis, the eyes, or the kidneys, and result in severe pain and what we call acute sickle cell crisis. They are precipitated by conditions leading to low oxygen tension like dehydration, infection, fever, hypoxia, cold exposure, pregnancy, and stress. The bone crisis results in acute or sudden pain of the bones. It's like an infarction in the bone and may be complicated by osteomyelitis. Inflammation of the bones in the hands results in dactylitis. In children, this results in painful swelling of the hands and feet. You may get affection of the joints, avascular necrosis of the hip, or priapism, constant erection of the penis if the penile vessels are affected. Affection of the pulmonary vessels may result in acute chest syndrome, sudden acute chest pain with dyspnea and coughing up to hemoptysis with low-grade fever. Should be differentiated from pneumonia. Abdominal crisis due to affection of the mesenteric vessels. It results in constant and sudden abdominal pain, nausea, and vomiting. The very serious complication of sickle cell disease is stroke due to occlusion of the large cerebral vessels. 2/3 of stroke in sickle cell disease, they start in childhood. Chronic hemolytic anemia is the usual in sickle cell disease, but there may be hyperhemolytic crisis. These kids, when there is recurrent infarction, affection of the small vessels of the spleen, you get recurrent infarctions of the spleen. By the age of 4 years, they are autosplenectomized. There is no function of the spleen with all its protective value. Also, sicklers have defective immune system, which is very important. The process of sickling also affects the kidney and results in kidney damage, and this occurs in every patient. Sequestration crisis is one of the very severe forms of patients with sickle cell disease. This means that it affects the spleen, it affects the liver. There is formation of sickling, occlusion of the blood flow within the liver or the spleen. So blood goes in and doesn't come out. This results in acute engorgement occurs in the spleen, only young children less than 4 years old, or in the liver. Acute onset of exaggerated anemia, hypotension, shock with enlargement of the involved organ. It's very serious, life-threatening. One of the other complications is hypoplastic crisis. They develop pancytopenia. It's very frequently related to parvovirus infection. Leg ulcers is also one of the complications of sickle cell disease. So by diagnosis, you make a blood picture. There is anemia. It's nomochromic nomocytic anemia. There is sickling. There is sickle cells in the peripheral blood. It's okay. You don't see sickle cell. You do the sickling test. Sickling test means addition of a reducing agent to the blood film, like sodium metabisulfite. This results in sickling. And hemoglobin electrophoresis will reveal a hemoglobin S more than 90%. When the patient is heterozygous for the hemoglobin S gene, we call it sickle cell carrier. The sickle cell carrier, his hemoglobin is usually normal. His hemoglobin S is 40% or less. He doesn't have manifestations except if he is exposed to conditions of very severe low oxygen tension, like anesthesia, like diving, like going to a mountain, like doing exercise in hot, humid weather. Sickle cell disease treatment most probably is prevention of vaso-occlusive crisis and stroke by good hydration, avoidance of precipitating factors, hydroxyurea therapy, and regular transfusion therapy. Whenever you get a vaso-occlusive crisis and stroke, good hydration, simple red cell transfusion. You may do exchange transfusion to decrease the hemoglobin S, and analgesics for pain. Treatment of infection, and most important, is vaccination to prevent infection. Anemia may require frequent blood transfusion. Hydroxyurea is a drug which is given. It makes to increase the amount of fetal hemoglobin, and this results in a decrease in the hemoglobin S amount, and this may result in a decrease, this is proved to result in a decrease in the long-term risks of sickle cell crisis. In the next module, hemolytic anemia part 4, we are going to discuss other hemolytic anemias. So I'm expecting you read and we are going to discuss. Thank you very much.